Hello everyone, I've compiled a list of 200 questions that are very important for you to know by the time you finish MBME 29. Each of these compilation videos takes about 20 hours of work, and so if you find this helpful, I would really love it if you could just like and subscribe. If you want a guaranteed way to pass this exam, visit ivtutoring.net to get access to a tutor from Harvard Medical School. Let's dive into question 1. Here we have a 35-year-old man brought to the emergency department after collapsing after a multi-day wilderness survival challenge. Fun fact, that was my first merit badge as a Boy Scout, the wilderness survival one. He has not eaten in 4 days and reports dizziness and fatigue. Physical exam shows dry mucous membranes and mild orthostatic hypotension. His breath has a fainty, fruity odor. Blood glucose, 61. Bicarb, 20. Anion gap, 16. We got some positive ketones. Urine analysis is also positive for ketones. There's no glucose in the urine. Which of the following most directly contributes to the ketone body formation in this patient's current state? So 35-year-old man, he's got 4 days of starvation. What we need to know for this question is that the brain can run on fat in a way. During prolonged fasting, the body burns fat for fuel, but the brain cannot use fatty acids directly. Instead, your liver converts that fat into ketone bodies. So thank you, liver. And that reaction can take place because of the buildup of acetyl-CoA from fatty acid oxidation. But there's a catch. The TCA cycle slows down because oxaloacetate is diverted to make glucose. So all that acetyl-CoA right here piles up and gets shunted into ketogenesis. And so this patient, after days without food, shows the signs of fruity breath, low glucose, and positive ketones. This guy's body is running low on glucose because he's starved, or you'll see untreated type 1 diabetes. So it has to have another fuel source. And that's where the ketone bodies come in. If your body has no insulin, the body's like, oh my gosh, I'm starving. And then fat gets broken down, fatty acids go to the liver, and normally acetyl-CoA enters into the TCA, the Krebs cycle. But during fasting or diabetes, oxaloacetate is used for gluconeogenesis. And that means the TCA cycle is going to be slowing down. So the result is, oh my gosh, we got all this acetyl-CoA. It's just sitting around. And that's when the liver converts the extra acetyl-CoA into, wait for it, ketone bodies. So we got a dude, hasn't eaten, no glucose, no big deal, let's burn fat. Check it out, we just made acetyl-CoA. And normally that goes to the TCA cycle to make energy. But during fasting or diabetes, the body uses oxaloacetate to make sugar. And this is a process you guys know called gluconeogenesis. And so there's not enough oxaloacetate to go through the Krebs cycle. Uh-oh, indeed. And so all this extra acetyl-CoA has nowhere to go. So the liver turns it into ketone bodies. So why are these ones wrong? Impaired hepatic uptake of glucose. That's seen in type 1 diabetes, but not starvation. Ketogenesis is driven by acetyl-CoA availability. Decreased NADH to NAD plus ratio. Actually, the opposite would happen. Beta oxidation increases NADH. I want you to think of NAD plus like a sponge that just picks up electrons. I want you to think of NADH like the used version. It's full of electrons. And so this ratio, that is to say NADH to NAD plus, tells us how much electron carrying fuel is available for energy reactions in the cell. And during fat breakdown, also known as beta oxidation, it creates acetyl-CoA, NADH, and FADH too. And so this electron carrying fuel availability ratio is going to be elevated. You're making more of NADH. And high NADH to NAD plus ratio slows down the Krebs cycle. Because NADH tells the cells, hey guys, we got enough energy. Look at me, I'm full of electrons. And this causes acetyl-CoA to build up. Why? Because it can't enter into that TCA cycle as easily. And what happens, as we now know, to the extra acetyl-CoA? Well, it gets shunted over to make some more ketone bodies. How about inhibition of carnitine transport to the mitochondria? That would block fatty acid entry. There'd be less beta oxidation. So that's the opposite. And E, enhanced glycolysis. That would be suppressed in fasting. Hepatocytes prioritize gluconeogenesis over glycolysis. And in case that's confusing, glycolysis is the breaking down of glucose to pyruvate to make energy. It's what the body does when there's plenty of glucose available. But if you're fasting or you have type 1 diabetes, there's not enough glucose inside the cell. And so this solution, our body's solution for turning glucose into pyruvate to make energy, is not a good one anymore. And so the liver's like, oh my gosh, let's switch gears. Let's stop breaking down glucose, glycolysis, and we'll start making glucose. And that is known as gluconeogenesis. So for step 1, you need to know you are not you when you're hungry. Fed state, glycolysis is on. You're burning that glucose. It's off here and on here. If you're fed, insulin is high, and if not, insulin is low and glucagon is high because gluconeogenesis is on. So enhanced glycolysis in hepatocytes is incorrect because the liver isn't breaking down glucose. It's trying to make more. Are you ready for question number 2? A 70-year-old woman undergoes evaluation for chronic aspiration pneumonia. During neurologic testing, A cotton swab is used to gently stimulate the left side of her oropharynx, but no gag reflex is elicited. What's damaged is the glossopharyngeal nerve. That's the afferent limb of the gag reflex. So if you touch one side of the throat and there's no gag reflex, but the other side works fine, then what's missing is the afferent sensory limb. Afferent is for your senses. I like to remember this by thinking, wow, that affected me. I felt that. Sensory. And that's carried out by the glossopharyngeal nerve. So cranial nerve 9 detects the stimulus on the back of the throat and it passes it to medulla. And then the vagus nerve, which is cranial nerve 10, contracts the muscles, causing the gag. And if one side does not sense anything, but the muscles still work well when triggered from the other side, then it's an afferent problem. Cranial nerve 9, glossopharyngeal. Now there's a lot more you could see on test day, so let's explain some of these other things, the high-yield buzzy stuff. Anytime you have absent gag, you should think of glossopharyngeal and vagus. Afferent, efferent. If, for instance, this question were to ask about cranial nerve 10 being damaged, then the stimulus would be detected, but no motor response would happen. The glossopharyngeal does sensory from the pharynx and taste to the posterior 1/3 of the tongue. There's something called the jugular foramen syndrome. That's if you have a mass like a tumor, metastasis, or a schwannoma that compresses the area of the jugular foramen, then you can get the loss of the 9, 10, 11. 9 is loss of gag reflex, dysphagia. 10 would be hoarseness, palate drop, uvula deviation. 11 is a weak shoulder shrug. You'd have the STM and the trap weakness. So if you see hoarseness, shoulder weakness, and a loss of gag reflex, it's a jugular foramen problem. Now there's also Wallenberg syndrome. That is caused by an occlusion of the posterior inferior cerebellar artery, stroking the lateral medulla. This affects the 9 and 10 nuclei, so you get a loss of the gag reflex, but it also affects the spinothalamic tract. You get a contralateral pain and temperature loss. You also get damage to the vestibular nuclei. Horner syndrome is super important. It's the triad of ipsilateral, so same side, signs of disruption to the sympathetic innervation to the face. Ptosis, meiosis, and hydrosis. Ptosis means the drooping eyelid. That's due to the loss of the superior tarsal muscle, which is sympathetically driven. Meiosis is the constricted pupils, and that's due to the loss of the pupillary dilator muscle, which is sympathetic. And then anhidrosis, that's the lack of sweating. So you have decreased sweat gland stimulation, and all those three are on the same side of the face. So it's a 3-neuron chain, and all this to say, if the location is the lung apex, then think of a Pancoast tumor, and that's ipsilateral Horner. If it's an internal carotid artery, then you think of dissection, and that's painful Horner syndrome. And a spinal cord trauma could be Brown-Séquard syndrome. It's like the hemisection. But yeah, basically know that ipsilateral means like the same side, and that's because the sympathetic fibers do not cross. They stay on the same side the whole way. So if you knock out the sympathetic chain on the right, then all symptoms will also show up on the right. Okay, just wanted to explain Horner syndrome, and I think this is a good illustration of the principle. Just review one part of a question, zoom out, get the whole picture, cover all the areas you're weak in. Ready for number 3? So here we have a 58-year-old man. History of hyperlipidemia presenting to the emergency department with a sudden onset nausea, chest tightness, dizziness. ECG shows ST elevation in these inferior leads. There's no crackles and clear jugular venous distension. Which of the following arteries is most likely occluded? Answer, right coronary. Now this is just a table you have to memorize. 2, 3, AVF, this is all right coronary artery. The lateral would be 1, V5, V6, AVL, that's the left lateral wall. V1 to V4 is covered by the LAD. The septal is V1, V2, that's also the LAD, but it's the septal branch. And the posterior is V7 to V9. But that's not on the 12 lead, right? That could be your RCA or the LCX. And there you see ST depressions in the V1 to V3, which is just the posterior. So here's our diagram. The inferior right here, lateral leads, inferior, lateral, septal, anterior. This is a cool mnemonic. 1, 2, F looks like inferior. This shows the magnitude and direction. And lead 1, there's the inferior, lateral, 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 septal, anterior. Last one, inferior, lateral, lateral, septal, anterior. Now, I might be wondering, what's all this stuff I hear about ST elevations? Well, ST elevations mean, for step 1, that you have a transmural infarction. So ST segment increase shows there's a full thickness injury from the epicardium to the endocardium. And the reason why is that dead myocardial cells cannot repolarize. You have persistent depolarization, and so the baseline shifts down, and the ST segment looks elevated on the EKG. This is caused by an acute thrombotic occlusion of a coronary artery. And so you have complete blockage, and that means there's no blood flow. So it starts with ischemia, then it causes an injury, and then there's an infarct cascade. Now, if this question asked about like the anterior STE with hypotension, then you'd say, okay, it's anterior, 1 to 4 LAD. If they asked about ST depression, then it'd be the posterior MI. If it's a young Asian male, then it's Brugada, a mutation that causes dysfunctional sodium channels, and it leads to polymorphic ventricular tachycardia, kind of like Torsades, but it's seen in young Asian males. At least that's how they'll ask about it on step 1. And that has a risk of sudden death, by the way. All right, question 4. We have a 55-year-old man with familial cholesterolemia. They started on new medication after he develops a statin-associated myalgias. Basically, he's got some aches and pains in his muscles and tendons. The drug works locally in the GI tract and is not absorbed systemically. Over time, the LDL levels decline, but he begins experiencing bloating and fat-soluble vitamin deficiencies. Which mechanism explains the lipid-lowering effect of the agent? Okay, so it's not statin, it's something else. And before we dive into the correct answer here, I think it's important to know the lay of the land. There's something called a very low density lipoprotein. That's the fat delivery truck that your liver sends out to deliver triglycerides. I mean, look at all those L's. You can tell that it's made by the liver. L, liver. And it's metabolized into LDL, which is more cholesterol rich. The purpose is to deliver triglycerides to muscle, fat, and tissues. And this eventually turns into LDL, and that carries mostly cholesterol. And before we dive into the answer, you'd also need to know what LCAT is. Now, this is the high-density lipoprotein that makes cholesterol safe to carry. It makes HDL useful. It turns the trash cholesterol into packable cholesterol that HDL can return to the liver. So very nice of LCAT to do that for us. We're almost there. What about cholesterol? Well, that's the bile acid resin. It binds the bile acids in the gut so that you can poop them out, and this forces the liver to make more cholesterol. So the effect is decreased cholesterol in the blood. So think of this as you're flushing out the bile, so the liver panics and uses more LDL cholesterol to make bile. And that means your LDL is going to drop because you're flushing it out and you need that stuff. You know, it's like tissues. Yes, they're useful if you're sick, but then they're used up and so you have less tissues in the box after you've been sick. All right, so this guy right here delivers dietary triglyceride to the body. It has tons of triglyceride. Very low density, that delivers the liver-made triglycerides. So it has some cholesterol, but lots of triglyceride. There's LDL, and LDL delivers cholesterol to the tissues. And this is mostly cholesterol. And there's HDL, and that picks up cholesterol from the tissues to the liver. So it has cholesterol esters. And then there's LCAT, and that makes cholesterol packable for HDL. LCAT's such a nice guy to help out the HDL like that. So which mechanism explains the lipid-lowering effect of this agent? There's a fat-soluble vitamin deficiency, and that's due to the loss of bile. Okay, so that's the first clue. We also know this acts on the GI tract. It's not absorbed. So we're binding those bile acids, and then we're excreting them in the feces. And as we spoke of before, this causes the increased LDL receptor expression, so the liver is pulling more cholesterol from the blood. Why? Because the liver loses bile acids, and it must make more. So it makes up its own cholesterol stores. So the end result is going to be an upregulation of LDL receptors because this is a bile acid resin, cholesterol. That's the drug. That's what we're introducing here. Acts at the binding site of bile acids, increasing their excretion. And so we compensate by making more LDL receptors. LCAT inhibition would disrupt the HDL maturation. But basically, we need to know this is bile acid resin, which binds bile acids in the gut, and it forces the liver to use its cholesterol stores to make more bile. So it lowers LDL by increasing LDL receptor expression. And the drug's non-absorbed gut-limited nature causes the GI effects and vitamin K deficiency, which explains things like prolonged PT, for instance, they could tell you about, or any of the A, D, E, K vitamin deficiencies, because that bile acid resin is gone. So the most important parts of this question are, we know bile acids are made from cholesterol in the liver. We know they're stored in the gallbladder, and they're released in the duodenum after a fatty meal. And their job is to emulsify fats, right? It helps you absorb dietary fats like A, D, E, K. Cholesterol binds bile acids in the gut, prevents reabsorption in the terminal ileum, and you poop out bile acids instead of recycling them. So there's less bile in the gut, and the fat cannot be emulsified properly. And so you get poor absorption of vitamins like A, D, E, K, fat-soluble vitamin deficiencies. A, causes night blindness, dry skin. D, bone softening, rickets, osteomalacia, hypocalcemia. E, neuropathy, hemolytic anemia. It's an antioxidant. And K, bleeding time. Next practice question, 60-year-old woman undergoes routine follow-up after completing adjuvant therapy. That's like the secondary therapy for estrogen receptor-positive breast cancer. She's taking daily oral medication that has been shown to significantly reduce the risk of infection in women with hormone-sensitive tumors. She has not experienced hot flashes. Which of the following best describes the mechanism of action of the drug that she's taking? Try to hide the answer. Don't look. But what should immediately come to mind here is tamoxifen and raloxifene. These are selective estrogen receptor modulators. That's why when I was creating these questions for the first time, I wrote down Serum, because this is a selective estrogen receptor modulator question. And these guys are cool because they're agonists in some tissues and antagonists. So you should be thinking of two things. One, breast tissue, and two, the endometrium. One, in breast tissue, both are antagonists. So tamoxifen and raloxifene block estrogen receptors in the breast. So this is used in breast cancer prevention or treatment. And our goal is to stop the estrogen-driven tumor growth. Okay, so they both work on the breast tissue. However, the endometrium is different. Tamoxifen is an estrogen agonist in the endometrium. It increases the risk of endometrial hyperplasia. Raloxifene, however, is an antagonist in the endometrium. So there's no increased risk of endometrial cancer, and it's safer in postmenopausal women. And the way to remember this, the way that I like to remember this, is T stands for terrible. It's terrible because it can cause the endometrium problems. And then R is respectful because it does not cause those in the endometrium. I don't know. whatever worked, right? But they both are agonists for bone protection. So it's also used in osteoporosis prevention in postmenopausal women, and especially is favored here because of the lower cancer risk, right? So it's protective of the bone. And they do protect bone, but they cause clots to form. Remember, they're selective estrogen receptor modulators. And so they mimic estrogen in some tissues and block it in others. And so in the bone, estrogen is protective, right? And so the serums are mimicking that. Lest we forget, estrogen inhibits osteoclasts. It's like, guys, we got to prevent that bone reabsorption. And serums act as estrogen agonists at these bone receptors. And so tamoxifen and raloxifene increase bone mineral density. And so it's used for osteoporosis. Now, estrogen's all over the body, right? And in the liver, estrogen is a procoagulant. Estrogen increases the synthesis of clotting factors. I don't know if you knew that. Which ones? 2, 7, 9, 10. And both tamoxifen and raloxifene act as agonists. The result is increased clotting factor production, so you have an increased risk of DVT. Wild, huh? So the bone, estrogen agonist. Liver, estrogen agonist. Breast, estrogen antagonist. Right? So you decrease that cancer growth. Endometrium, tamoxifen is terrible. It's an agonist there. Increased cancer risk, but it's an antagonist there. It's respectful of the endometrium. Hopefully that made tons of sense. And that's why your answer is competitive blockade of estrogen receptor in the breast tissue. This is a serum. That's what it does. You can look at these associations and these buzzwords. Feel free to pause, but we're going to be moving on, folks. I want this to be as efficient and high yield as possible. My goal is you guys are sitting at home like, oh my gosh, I can't study anymore. And then you found this YouTube channel. You're like, oh, sick. Let's get the popcorn going. Okay, question 6. We got a new nasal spray, baby. Seasonal allergic rhinitis. We got 200 adults randomly assigned to receive either the spray or the placebo. What's the answer? This is a randomized control trial. There's a lot of anxiety to pick something as simple as a control trial, which is like the backbone of all of science, randomized control, the gold standard. But the takeaway here on step 1 is pick what you're familiar with. They're testing high yield topics at the end of the day. If you keep picking things that you're familiar with and have confidence, then you're going to do well. Let's say they give you a weird one, case control. Well, for this one, I want you to think of the O-odds ratio. For example, here you'd compare patients with lung cancer versus without, and you check their prior smoking status. So you start with the outcome, another odd outcome. See, this is how I remember it, O for case control. Another one they can give you is a crossover study. That's where each subject gets both treatments, and then they're separated by a washout period. So each subject is essentially their own control. And so one group would get drug A and then drug B, and then the other group gets the reverse. That's crossover. I think of BoJack Horseman. Wow, is this a crossover episode? Only for both switching and reversing. That's the answer that I give BoJack in my mind as I study for step 1. Or rather, Mr. Peanut Butter. I digress. That's randomized control. Cross-sectional is a snapshot in time. It measures the exposure and outcomes simultaneously. And what they're always going to test you on for this one is the prevalence. And there's no temporality for this. So for an example, they could survey 5,000 people on smoking and the current lung function today in time. That's cross-sectional. Prospective cohort study starts with the exposure, and then you follow forward. In this one, you study risk factors. Risk factors for cohort. We assess the relative risk for prospective cohort. That's the easiest way to remember this. Once I had that in my brain, these questions became super easy. All right, for the next question, whenever you see these images, you should think of monosodium urate. These are gout. For some reason, it looks like Star Wars. I don't know. But yeah, this is gout. You see it on test day, you just click it immediately. And here we have a 58-year-old man who's got acute pain and swelling of his right ankle that began overnight. He has a history of hypertension and chronic kidney disease. Examination shows erythematous, tender, and warm ankle joint with limited range of motion. Atherocentesis is performed. Synovial fluid has 25,000 or greater white blood cells and needle-shaped crystals that appear yellow. Okay, this is gout. The answer is C, but equally interesting are the buzzwords and associations for other answer choices. If they said needle-shaped negatively bifringent crystals, negative, needle negative, and gout is a negative condition, you do not want it. Pseudo-gout, a little bit more positive. I don't know, that's just the way I think about it. If they show enveloped or dumbbell-shaped, then it is going to be calcium oxalate, and that's often seen with ethylene glycol poisoning. If you see cholesterol clefts, then that's chronic inflammation, often rheumatoid effusions and atheromas. By the way, an atheroma, also known as an atheromatous plaque, is a buildup of fats and cholesterol and other substances in the inner layer of the artery. So calcium pyrophosphate, that's linked to aging, maybe hemochromatosis, hyperparathyroidism. These conditions cause inorganic pyrophosphate levels or calcium levels, and they promote the CPPD crystal formation. That's calcium pyrophosphate deposition disease. Calcium oxalate, that's seen with ethylene glycol poisoning, vitamin C overuse, or Crohn's disease. It's where you have fat malabsorption that increases the oxalate absorption. Our answer is sodium monourate, and that's just gout, right? It's associated with cell lysis, high purine turnover, tumor lysis syndrome, or alcohol use. And cholesterol is just going to be long-standing effusions with rheumatoid arthritis due to the chronic synovial inflammation. So let's see what these explanations are. Classic gout. Negatively bifringent. Calcium pyrophosphate has the rhomboid-shaped. Kidney stones would be seen with calcium oxalate, not the joints. Cholesterol is found in lipid effusions. Hydroxyapatite would be calcific tendinitis. Now, the last thing that might test you on with this is oxalate is a normal byproduct of metabolism, right? From oxalate, vitamin C, and it's usually excreted in the urine after it binds to calcium in the gut. So it's got to find its friend calcium. And if oxalate levels are too high, or if calcium's not available, then it'll form insoluble calcium oxalate crystals in the renal tubules. And these crystals can obstruct the tubules, and it causes acute tubular necrosis or renal failure. And this is seen in antifreeze, ethylene glycol poisoning, right? Because it's metabolized by alcohol dehydrogenase, glycolate form, which then leads to oxalate. So anytime you increase oxalate or decrease calcium, you have to be worried about these guys, because this is going to be a metabolized oxalate, and you have excess oxalate load, and then you have crystal formation. In Crohn's disease, the fat binds calcium in the gut, so you have less calcium to bind the oxalate, right? The fat is taking care of the calcium in Crohn's. And so free oxalate is now absorbed in the colon instead of being excreted, and that leads to secondary hyperoxaluria, and you get kidney stones. So envelopes or dumbbell shaped. Oh, and by the way, why is it high anion gap metabolic acidosis? That's because obviously ethylene glycol causes the formation of these acids. And these are organic acids, and so they donate. What do acids do? They donate, thinking back to organic chemistry in college, hydronium ions, and they lower the pH and they consume bicarbonate. So it increases the acid load. So you deplete bicarbonate, causing metabolic acidosis. And that's your like mud piles, right? Methanol, deformic acid, uremia, renal failure, diabetic ketoacidosis. I should probably write this down. Mud piles. Methanol, uremia, diabetic ketoacidosis, propylene glycol, bing bing, isoniazid and iron, lactic acidosis, ethylene glycol, and S stands for salicylate. That's your late phase. So yeah, watch out for hypocalcemia, crystals in the urine with calcium oxalate. You treat it with fomepizole or ethanol. Those are competitive inhibitors of alcohol dehydrogenase, and also bicarb for acidosis. And you can even do hemodialysis if it's super severe. So yeah, fomepizole is the antifreeze antidote. That's pretty much all you need to know about it on step 1. But basically it just blocks that first step. You're preventing the formation of the toxic metabolites. You're inhibiting alcohol dehydrogenase. All right, next we have a 13-year-old girl brought to the clinic for school physical. She's got concerns that she's significantly shorter than her classmates. She's always been the small size, and her mom didn't start menstruating until 16. In the 5th percentile, weight 30th, this is a late bloomer. And our condition causes a temporary delay in the skeletal growth. You have normal predicted adult height. It's just slow but consistent. Now, if the growth curve were to flatten, so like if it's not growing consistently, if it like flattens, then that's going to be an endocrine or a systemic illness. But if you have normal velocity but low percentile, then it could be familial short stature. So familial short stature, that's like normal velocity. Here we have delayed, so it's constitutional. Next question, we have a 24-year-old woman has a 5-day history of joint pain, blotchy rash over upper limbs. She started treatment with a mouse-derived monoclonal antibody for severe aplastic anemia. She's got tender swollen wrists and knees, erythematous maculopapular lesions on her chest and forearms. Lab studies show leukocyte count of 7,800, ESR of 55, complement C3 of 68, which is low. What describes the mechanism? The answer is immune complex deposition. She's got serum sickness, which is type 3 hypersensitivity. It's 1 to 2 weeks after you have a foreign monoclonal antibody. We have fever, arthralgia, rash, low complement. Arthralgia is just pain at your joints, by the way. Here are the other answers and why they're wrong. Now, there's a mnemonic that you can know for these type of hypersensitivity reactions. Acid, because type 1 is allergy or anaphylactic. 2 is cytotoxic, that's antibody mediated. 3 is the immune complex. And then 4 is delayed, and that's T cell mediated. So the anaphylactic has IgE mediated activation of mast cells, and this requires a prior sensitization. So here you have histamines, prostaglandins, and they cause vasodilation, bronchospasms, and the onset here is just minutes. So think like a bee sting, peanuts, shellfish, penicillin, allergic rhinitis, like hay fever, asthma, eczema, like atopic dermatitis, urticaria, which is hives, food allergies, things like that. Type 2 is a cytotoxic antibody-mediated reaction. And the mechanisms here are through IgG and IgM, and these bind to the antigens on cell surface, and they trigger complement activation, which is ITP. You could also have receptor-related problems like Graves' disease, myasthenia gravis, pemphigus vulgaris, that's the anti-desmoglein. So pemphigus vulgaris is the anti-desmoglein. Bullous pemphigoid is anti-hemidesmism. And those are all type 2. Then there's type 3, that's where you actually form the complexes. And these guys are IgG, the antigen antibody complexes that form in circulation, and they deposit in the tissues. So they activate your complement system, and that's why we have a low complement in this question. Attract the neutrophils, inflammation of tissue damage, and the onset is like days. So here's serum sickness, right? Antivenom, monoclonal antibody, penicillin. That's the stuff you think of. Another big one, too, is going to be lupus, the DNA, anti-DNA complexes that form post-streptococcal glomerulonephritis, polyiteritis nodosa, hypersensitivity pneumonitis, that's like farmer's lung. All these immune complex depositions, complement activation, low C3, neutrophils, fibrinoid necrosis, vasculitis. These are all type 3 hypersensitivity reactions. Type 4 is the delayed cell-mediated type. That's where you have the CD4 Th1s or the CD8 cytotoxic T cells, and there are no antibodies involved. This is macrophage and cytokines that drive the inflammation. The onset is 48 to 72 hours. So here you think of like a skin test, tuberculosis skin test. Contact dermatitis, that's like poison ivy, nickel, latex even. Immune, you could also have some autoimmune problems like type 1 diabetes. That's your beta cell destruction by your CD8 positive T cells. Multiple sclerosis, that's where you have T cells against your myelin basic protein. Hashimoto thyroiditis, Guillain-Barré, celiac, and graft rejection. So like acute transplant, graft versus host disease. You have a delayed response that's T-cell mediated. There's macrophage activation granulomas, no antibodies, and induration after 48 hours. So that's everything there is to know about type 1, 2, 3, and 4. And then you look at this one, you go, okay, we've got serum sickness. That's a type 3 immune complex. This is 1 to 2 weeks after the exposure of monoclonal antibodies. They have the mouse monoclonal antibody. And so you have low complement. This is definitely going to be activation. And so our answer is C. That's how you do it. All right, for question 10. Here we have a 55-year-old man with a 5-year history of rheumatoid arthritis, has worsening fatigue over the last 3 months. He denies blood loss, no change in diet, takes methotrexate and NSAIDs. Lab results show all of this good stuff. What's the cause of his anemia? The answer is increased hepcidin-mediated iron sequestration. This is anemia of chronic disease. This is also known as anemia of inflammation. Very common tested cause of normocytic, microcytic anemia, especially in hospitalized or chronically ill patients. So they're probably going to have like lupus. They're going to be on some corticosteroid, prednisone, for instance. And this is where you're trapped in the storage, right? You have anemia of inflammation. And what's interesting about this guy is that the iron is totally present. It's just like locked away. And interestingly, you have increased hepcidin from the liver, which inhibits ferroportin. Basically, iron is present, but you can't use it because hepcidin is a peptide hormone that's produced by the liver, especially during inflammation. This is triggered by IL-6. So inflammation time, right? And it binds hepcidin to ferroportin. And that binding triggers internalization and it degrades the ferroportin and it prevents the iron export into the plasma, serum iron, even though there's increased ferritin. And I like to think of TIBC as how much your body wants the iron. It doesn't because it has a lot of it, so it's low as well. And the MCV is normal to low. So ferroportin is the only known cellular iron exporter. And so hepcidin is the master iron regulator. So it's like the lock on the iron gate, right? You have inflammation and that locks and it tightens things. So imagine your dude right here. He's an enterocyte in the gut, right? He's just absorbing dietary iron and he sends the iron to the blood. Well, hepcidin, triggered by the IL-6 active inflammation, is like, hey, bud, stop that. And so hepcidin blocks that export. Or imagine you got another guy. He's a macrophage and he's like, ooh, I'm going to recycle iron from the senescent red blood cells. I'm going to release the iron. Well, hepcidin goes, let me take that. I'm going to trap that iron. And imagine our last dude is like hepatocyte. He's like, ooh, I'm going to store the iron. I'm going to regulate the plasma iron. And then hepcidin's like, nope, you're not going to release that, bud. So it's just like stopping things. It's binding to ferroportin and it's just halting things and it's being trapped. And so you're withholding iron from the pathogens, right? From an evolutionary standpoint, that's what we're doing because pathogens need iron too. And so your body's like, oh my gosh, I got all these pathogens. I'm not going to share my iron. But in chronic inflammation, right, this protective mechanism, which is awesome, thank you, evolution, is now maladaptive. And you have anemia, right? You need iron too. Oh man, the body's so funny. But yes, this is a hepcidin-mediated blockade of the iron release. All right, folks, that does it. We finished the first 10. I'm going to take a break, maybe do a couple curls with my calcium oxalate dumbbells. And I want you guys to stretch your legs, do something fun, treat yourself. You're going to do great things with your life. Just know you're going to get through this. You will get through this. It takes a little bit more time. Who cares? Life is long and short at the same time. Enjoy yourself. Like and sub if you like this channel. Hoping to give you guys high quality resources. We got a lot of things. Check out the link in the description if you want tutoring, kind of like what we did today, but more personalized to you, guaranteeing that you're going to get a pass on step 1. Click the links in the description. You can get an in-person tutor, and we're also launching some courses soon. Take care, y'all. We'll see you soon.